Today, we are looking at a document that you almost never get to see outside of a hospital. It's the minutes from a tumor board.
Yeah, and if you're not familiar with the term, it's basically the medical version of a war room.
Exactly. It's where you have surgeons, radiologists, pathologists all in one room, arguing over the cases that have no easy answers.
It's really where the textbook stops. You have all these different specialists who see the body in totally different ways, trying to hash out a single plan for a patient in very serious trouble.
And the patient at the center of our deep dive today, a man named Wasim, was definitely in trouble. He's 45, works as a hawker, so he's on his feet all day.
But the real headline here, I think, is the duration.
Oh, absolutely. The case file says he presented with a 12-year history of nasal obstruction.
12 years. Just, let that sink in for a second. This isn't a bad cold. It's over a decade of just bluff.
And it started gradually, which is maybe why he waited so long. But by the time he gets to the hospital, the file says the obstruction was complete. He literally hadn't breathed through his nose in years.
And all that time, he had this profuse, yellowish, watery discharge.
Yeah.
That detail is actually a really important clue.
Right, because the notes made a point of saying it was not foul smelling. I mean, after 12 years of blockage, you'd expect a really nasty infection, wouldn't you?
You'd expect something awful. A foul smell points to tissue death, necrosis, or certain types of bacteria. The fact that it didn't smell like that suggests the problem was a solid mass filling the space, not just, chronic, rotting sinusitis.
And they ruled out the usual suspects. No history of allergies, no asthma, so this isn't your standard case of nasal polyps.
Exactly. Standard polyps usually come with that whole inflammatory picture. This was something else entirely, something growing.
And he finally came in, not just because he was stuffed up, but because it had turned into pain. He had headaches and this specific pain over his left cheekbone.
And that's the classic sign. That's when the masses run out of real estate. The sinuses are bony boxes, and when a tumor fills that box, it starts to push on the walls. That's what causes the pain.
So let's picture this. The doctors are just looking at him now, before any scans. And the external signs are, they're pretty disturbing. The report says mild telecanthus.
Which is a clinical way of saying his eyes were literally being pushed apart.
That's a terrifying thought.
It means the mass growing between his eyes had enough force to actually widen the bridge of his nose.
And on top of that, proptosis on the left side, so his left eye was also bulging forward.
Yeah, you've got this incredible pressure building from behind and between the eyes. And when they touched his face, his forehead and cheekbones were tender. The tumor was pressurizing his whole facial skeleton.
The detail that really got me, though, was the oral exam. They look in his mouth, and there's a bulge on the roof of his mouth.
Think about that. The tumor is starting in his nose, but it's so big it has eaten through the floor of the nose and is now pushing the palate down. It was so large it was pushing his uvula off to the side.
It's coming from every direction. Up into the eyes, out into the face, down into the mouth.
A total takeover of the space.
And yet, and this seems almost impossible, his nerves are okay, his vision, his eye movements, they were all still intact.
It is remarkable, and it tells you something about this specific kind of tumor. It tends to push and remodel bone rather than, aggressively invade nerves right away.
Yeah.
So the structure was distorting, but the machinery was still technically working.
Technically working feels like it was hanging by a thread.
Oh, it was. A very, very thin thread.
So they get him to imaging, they start with the CT scan, and the word that keeps coming up in the notes is destruction.
The CT is the roadmap of the damage, and it showed this soft tissue mass filling, everything. The frontal, ethmoidal, maxillary, sphenoid sinuses, a total blackout.
And it wasn't just sitting there, it had eaten away the nasal septum, the turbinates, but the part that scared me was the lamina papyracea.
That's the critical border. It's that paper-thin bone separating the nose from the eye socket, and the CT showed it was gone. Eroded through on both sides.
So there was literally nothing separating this tumor from his eyes.
Nothing but soft tissue. And the CT only tells you about the bone. To figure out what the tumor actually was, they needed the MRI.
And the MRI report had this very specific jargon. It said the tumor had a heterogeneously hyperintense signal on T2 images.
Right, which on a scan creates a very specific look. We call it a cerebriform pattern.
Cerebriform, like a brain.
Exactly like a brain.
Yeah.
On the MRI, the tumor has these swirls and folds that look just like the surface of a brain. That is the absolute smoking gun for this diagnosis, even before biopsy.
And the MRI also confirmed the danger zones. It was extending into the orbit, into the eye socket.
Yes, into what's called the extracamal space. But critically, it was also infiltrating the superior rectus and superior oblique muscles.
The muscles that actually move the eyeball.
The very same. So it's tangled up in the mechanics of his vision.
And it didn't stop there, did it? It also went up.
Up towards the brain, the MRI showed erosion of the cribriform plate. That's the delicate sieve-like bone separating the dirty environment of the nose from the sterile area around the brain. That barrier was breached.
So after the biopsy, this thing gets a name. Sinonasal inverted papilloma. And this is where I get confused because the doctors call this benign.
Yes, the trap of medical terminology.
To me, benign means safe, leave it alone. But this thing is eating through his skull.
Exactly. Benign here is a microscopic definition.
Yeah.
It means the cells themselves aren't cancerous. They won't spread to his lungs or his liver.
But their local behavior is anything but benign.
Precisely. In the skull base, location is everything. A benign tumor that crushes your optic nerve or pushes on your brain is just as lethal as cancer. It just kills you differently.
And Wasim's case was especially rare because it was on both sides.
Yeah, IP is almost always a one-sided problem. Bilateral cases are only about 5% of the total. So the tumor board officially staged this as Crow's T4, the highest stage, advanced disease.
So we're back in the war room, pills are off the table, radiation is off the table, it has to be surgery.
Complete surgical excision is the only option.
But when I read about the size of this thing, I just assumed they'd have to, make a huge incision on his face to get to it.
10 or 20 years ago, that's exactly what would have happened. A big cut, a lot of scarring.
But they planned an extended endoscopic endonasal approach.
Correct.
You're telling me they took all of this out through his nostrils?
Through the nostrils. It's like building a ship in a bottle, but in reverse. You're deconstructing something massive through a tiny opening.
How is that even possible?
Well, you have to make the opening bigger from the inside. The plan called for removing the inner walls of both cheek sinuses, a bilateral medial maxillectomy, just to create a corridor for the instrument.
And then there's this procedure, the draft 3. It sounds incredibly complex.
It is one of the most complex sinus procedures there is. The surgeon has to use a drill, working up inside the nose, to remove the floor of both frontal sinuses in the forehead.
They're drilling the bone of the forehead from the inside, millimeters from the brain.
That's it. A slip there isn't just a mistake. It's a neurosurgical catastrophe. They create one big, common cavity so the forehead can drain forever. It's a last resort procedure for cases like this.
Okay, let's talk about the eye. The tumor is tangled in the muscles. The surgeons want to save his vision, but how do they decide where the line is?
That's the red line they talk about in the plan. The goal is orbital preservation. But the board was very clear. If the surgeon gets in there and finds it has actually turned into cancer, or if it's wrapped around the optic nerve itself,
They have to take the eye.
they perform an excineration, you remove the eyeball and all the contents of the eye socket.
I can't imagine the pressure. You're dissecting tumor off a muscle. Knowing one bad finding means the patient wakes up lying on that side.
It's an immense responsibility.
And what about the hole in the skull base? Once you pull the tumor off the brain lining, you've got a direct leak, right?
You do, a CSF leak.
Yeah.
Leave that open and the patient gets meningitis. So a huge part of the surgery is the reconstruction.
Using something called a nasoseptal flap.
Right. Before they start the main tumor removal, they carefully raise a big piece of the lining from the nasal septum, keeping its blood supply alive. At the end of the case, they rotate that living tissue up and use it to patch the hole in the skull base.
It's like patching a tire from the inside, using a piece of the car's own upholstery.
That's a perfect analogy. It seals the brain off in the nose again.
So let's say it all goes perfectly. Wasim wakes up, he can breathe, he can see. Is he cured? Is he done?
And that's the hard truth about inverted papilloma. You're never really done. This thing loves to come back.
So surveillance is key.
Mandatory. The board set out an intense schedule. He has to have a scope put in his nose every 3 months for the first 2 years.
4 times a year, plus an MRI at 6 months, and then yearly imaging after that.
For a minimum of 5 years. This is a long-term relationship with a surgeon.
And no chemo or anything to clean up stray cells.
No role for chemo. Radiation is kept in reserve, but only if it comes back as cancer, or if it's impossible to remove completely. The goal is to get it all with a knife.
It's an incredible story. When you look back at this whole case, what's the one thing that really stands out to you?
For me, it's the resilience of the body. The fact his vision was still working, despite having his eye literally pushed out of place. It's just baffling. It shows how much we can adapt. Up to a point.
And that adaptation is what I can't stop thinking about. The scariest part of this whole file isn't the drill or the tumor, it's the 12 years.
He's lived with it.
He lived with it, which proves that our brains are just incredibly good at normalizing a bad situation. If the change is slow enough, millimeter by millimeter over a decade, you just adapt. You learn to be a mouth breather. You ignore the pressure. You get used to it.
The whole frog in boiling water scenario, but for our own bodies.
Exactly. If he'd woken up one day with his eye bulging, he would have been in the ER that morning. But because it took 12 years, he waited until his skull was eroding.
And that delay completely changed the surgery. At year 2, this would have been a much simpler case. At year 12, it was a high-wire act with the brain and eye on the line.
So the final thought for you listening is this. What new normal have you slowly accepted in your own life, in your own health? What little signal from your body have you been ignoring just because you've gotten used to it? Because sometimes chronic is just another word for a crisis that's taking its time.
That is a very sobering thought to end on.
Thanks for diving deep with us. We'll see you in the next one.